care and physiotherapy. Firstly we start procedure counseling and preparation are essential. Assess fitness and manage risk factors. Clearly explain the patient about procedure risk, benefits and outcomes, and align patients expectation with the healthcare professionals goals. So basically, post-operative care start after last suture and removal of surgical drapes. And key concern is removal of throat pack. Suction of mouth should be avoid breathing and manage oral secretions. If reversing respiratory depression with naloxone and flumazenil, after that, observe the patient at least for 2 hours. Incomplete reversal of muscle relaxant is common in hospitals. When patients are not warm during surgery and they are cold, the reversal of muscle relaxant.
Ma'am, please change slide. Not moving.
I change.
But he is not visible.
Not visible.
Yes, ma'am. Only immediate post-operative care day 0 visible. Second slide.
I will join again.
No, ma'am. No, ma'am. Please share.
Okay. Its incidence is high. Anesthesia depresses respiratory and produce ventilation perfusion mismatch and the pain severing that increase the demand for oxygen. After general anesthesia, there always is some degree of alveolar collapse resulting from a decrease in functional residual capacity which may take days and weeks to return to the baseline. Recovery, second point is the recovery from the general anesthesia. Recovery is gradual process dependent on the continued redistribution of the anesthetic drug in the body together with elimination or metabolism. The process is time to result in emergence from anesthesia as close as possible to the completion of the surgery. A considerable residue of drug may remain, especially in skeletal muscle, so that secondary peaks can occur in the plasma concentration peaks following rewarming and the restoration of muscle blood flow. The slow release of the from muscle and fat prevents full recovery of cognitive functions or for many hours will potentiate the effect of the additional sedative drugs. Monitoring after the surgery, vitals monitoring is mandatory, like blood pressure, pulse, oxygen saturation, and respiratory state will measure the and recorded regularly. If an arterial catheter has been inserted, blood pressure and pulse reading can be observed on a monitor constantly. Measurement of the central venous pressure may be required for patient with poor cardiorespiratory reserve or where there have been large volume of fluid administered or major fluid shifts are expected. The patient chart will also record all full that has been given during and since the operation together with fluid loss. Respiratory care, mechanical ventilation may be required in the early phase of recovery. This can be vary from prolonged endotracheal intubation to intermittent positive pressure ventilation to supplemental oxygenation by face mask or nasal prongs. After in immediate care after surgical procedure, assessment of the surgical sites like oral cavity, look for any bleeding, suture gaping, and oral cavity suction should be done by Yonkers suction in every 2 hourly and or according to need. Watch for any nasal bleeding if nasal pack present in neck. Watch for any neck swelling, hematoma, drains. Look for they are functional and not. If not functional, then look for any connection between neck and tracheostomy site and manage accordingly. If tracheostomy present, then tracheostomy tube care should be done. Ensure firstly ensure tracheostomy tube patency and check for adequate air plus present or not. And suction of the tracheostomy done should be in every 2 hours with 0.9 normal percent saline, and suction should be done according to the need, and ensure humidification of the tracheostomy tube. In general post-operative care, firstly we start with the vitals monitoring. In this, SpO2 monitoring should be done in every 4 hours. Temperature monitoring, blood pressure and pulse rate regularly monitored. And for international patient, the interpreter should be available for 24 hours. In post-operative fever, it is common for first 40 to 48 to 72 hours. Leukocytosis is the response to the tissue damage. So basically, drop in WBC count is more worrisome than rise. And for post operative fever, we can use biomarkers like procalcitonin. If fever more than 72 hours and high grade, then find out the cause of fever and send fever profile. 5 Ws of the post-operative fever: wind. In in this, most common cause of the fever is atelectasis, water, urinary tract infection, for wound infection, walking, deep vein thrombosis, and Vanderducks. They are beta-lactams antibiotics. They produce fever: vancomycin, isoniazid, sulfa drugs, and NSAID. In wind, atelectasis occur less than within the 48 hours of the surgery, and pneumonia occur more than 48 hours of surgery. Basically, these are occur on the fever uh, on POD first and second, and presentation like dyspnea, cough, increase work of breathing, and decreased saturation, and on in auscultation, crackles are present. Urinary tract infection occur between POD third and to fifth, and in this patient, symptoms presents with dysuria, increased urinary frequency, lower abdominal pain, and in wound surgical site infection, it can be deep or superficial, and it occur after the POD fifth, generally on POD fifth to 7, and in this, pain present around incision, erythema and edema, and tenderness present over the surgical site. Uh, in deep vein thrombosis, there are vascular causes. It can be deep vein thrombosis and phlebitis and central line infection, and it can happen occur after the POD first and or beyond. Due to the it is happen due to the immobility and prolonged peripheral or central line. On examination, in deep vein thrombosis, painful unilateral limb with swelling. In phlebitis, erythema, edema at the site of the peripheral IV line, and in central line infection, there is purulent drainage present. Drug fever can also be happen, or it can occur most common after the 7 days, but can occur any time. Diagnosis of exclusion should be after all causes have been ruled out. Withdrawal any substance, if patient taking before the surgery any substance, so or it occur after the 72 hours of the surgery. Wonky glands, in this, it can be happen due to the adrenal insufficiency, or it can happen within 12 hours of the surgery. And thyroid storm, it will be occur after 48 hours. Post operative guideline for nausea and vomiting. Risk factors in this condition, it occur first 24 to 48 hours, and for this risk factor, female gender, age less than 50 year, previous history of the post-operative nausea, vomiting, and use of opioids during intraoperative and the post-operative period. Recommended dose is 4 milligram ondansetron at end of surgery. So post-operative care for the nausea and vomiting. In adult patient, there is a risk factors patient related like female, gender, age less than 50 year, and previous history of the nausea, vomiting, and motion sickness, and if patient is non-smoker, and other factors like environmental factors, post-operative use of opioids, and it's depend on type of surgery and duration. And in children's risk factor, surgery is greater than 30 minutes, age more than 3 years, and history of the previous history of the vomiting. So basically we consider on the basis of the patient's preference and cost effectiveness and the reducing baseline risks. On the basis of it can be divided in low risk group, medium risk group, and high risk group. In low risk group, only wait and watch. In medium risk group, we can use 1 to 2 intervention, and in high group we can more than use more than 2 intervention. In medium risk group, we can use 5-HT3 antagonists like ondan, centron, and the dexamethasone. And in high uh, risk group, we can use other factors also. We use regional anesthesia during the surgery, and propofol anesthesia during surgery, and NK1 receptor antagonist can be used. Post-operative management of post-operative hemoglobin practice guideline 2006
आ गया वो छोड़ हो गया हेलो
guideline 2006 American Society of Anesthesiologists.
लॉगिन हो गया पर देखते हुए
Hemoglobin, if hemoglobin less than 6 gram per deciliter is a strong indication for transfusion. There should be no blood transfusion if hemoglobin is higher than 10 gram per deciliter. For between 6 to 10 gram per deciliter, it is based on the base clinical judgment, such evidence of organ ischemia, bleeding, intravascular volume, and patient's own risk factor, which can predispose patient to have low cardiopulmonary reserve and high oxygen consumption. The average blood volume that can patient may lose and still
हो गया इस पे कनेक्ट
maintain hemoglobin at safe level is about 25% of hemoglobin a drop from baseline. This recommended 25% threshold can actually result in numbers that are higher than most physician experts. Wound care, most surgical wounds undergo primary closure, in which way there is minimal tissue loss, and wound edges can be satisfactorily approximated. In initial phase of healing, there is only minimal tensile strength in the wound as remodeling of the collagen fibers has not occurred. As such, additional support in the form of sutures, staples, and TAMs is required until full remodeling and epithelialization occur. Wound care in head and neck cancer patient, in total laryngectomy patient, stomal care should be done, and watch for any signs symptoms of like pharyngocutaneous fistula like fever, erythema around the stoma, discharge uh, from stoma. Recommendation of preventing surgical site infection in post-operative care: dressing and cleaning the wound daily, and use antiseptic technique for changing or removing dressing untouched for till 48 hours after the surgery. Using sterile saline for wound cleaning during this period only if necessary. And we can use interactive dressing for surgical wounds for the healing by secondary intentions. Refer to a tissue viability nurse, another health care professional with tissue viability expertise for advice on appropriate dressing for surgical wounds, and they are healing by secondary intention. Antibiotic treatment. Antibiotic treatment should be given if surgical site infection present like cellulitis, either de novo or because of treatment failure. Choose an antibiotic that cover most likely causative organism and consider local resistant pattern and result of microbiological test. In head and neck surgery, common pathogens for surgical site infection: Staphylococcus aureus, Coagulase positive, negative Staphylococci, Streptococci, bacterioids, and Peptostreptococcus. In head and neck surgery, if wound is clean, no antibiotic needed. If wound is clean and placement of prosthesis, any tubes, then we can use antibiotic cefazolin and cefuroxime. And if for drug allergy present for these antibiotic, we can use clindamycin. If clean contaminated cancer surgery, we use combination of cefazolin plus metronidazole or with cefuroxime and metronidazole, and we can use ampicillin sulbactam. If allergy present, then can we use clindamycin. Flap care, post-operatively flap care. Many free flap protocols include for warming of the patient and room to promote peripheral vasodilation and perfusion. Pressure on free flap should always be minimized, and as excessive pressure may impede arterial inflow or venous outflow. Surgical dressing should be examined and confirmed to be not excessive tight. More than 95% free flaps compromise occurs within 72 hours of post-operative period. In this flap failure, venous thrombosis is more common than arterial insufficiency. Mechanical stress exerted by hematoma and vascular kinking due to the flap geometry also potential cause for flap failure. Flap monitoring should be done in first 24 hours in for every hours, and in every 2 hours for following 24 hours, and every 4 hours for remaining duration of admission. Scratching and the pricking of the flap with a small hypodermic needle to elevate the timing and color of bleeding is useful maneuver. If slightly delayed, bright red bleeding seen after scratching and pricking, it is sign of the veil perfuse flap. And absence of any bleeding and brisk egress of dark deoxygenated bluish blood, and this is suggestive of venous congestion. For extremity free flap, the involved limb should be elevated to help control edema, and which might otherwise accumulation and can cause pressure on the microvasculature of the flap. So limb should be elevated. Finally, activity restriction including weight bearing status and the range of motion should be carefully reviewed, and as they may impact pressure or tension on free flap. For pedicle flaps like myocutaneous and osteomyocutaneous flaps based on a feeding vessel on muscle and perforator to the skin pedal, like a pectoralis major muscle, dorsi flap, may be used in one state operation to replace skin, and because they also contain muscle, they have adequate bulk to repair defects and may be used to import bone. Uh, for check for free flap viability, we can use capillary refill test. Cutaneous blood is expunged from a small area of free flap by temporarily applying digital pressure, and then pressure is released to observe the return of blood flow into that area. Typically, capillary refill is described in terms of time or whether normal it is 2 to 3 seconds. Delayed capillary refill indicate an arterial inflow problem. In contrast, excessively brisk capillary refill indicate venous outflow problem, as flap tissue become engorged with blood due to the continued arterial inflow. Color of flap. Color of the flap skin should exhibit a pink color similar to the normal tissue. If color is pale, problem with the arterial anastomosis resulting in decreased blood flow into the flap. If color is purplish, this may indicate the venous problem with the venous anastomosis and with the accumulation of the venous blood. Temperature of the flap. Temperature of flap should be normal at the should be normal as normal adjacent skin. Temperature can be assessed via measurement and the or physical examination, or it is the subjective examination. If there is a difference of 1 to 3 degrees centigrade of temperature, then it can indicate vascular issues of flap. Turgor of the tissue depends on vascular inflow and outflow balance. Normal free flap turgor matches with normal tissue. Diminished turgor, it is possible in the arterial inflow issue, and the if uh, wrinkles and prominence present on the flap, it indicate arterial inflow insufficiency. If excessive swelling and firmness present, due to the it likely due to the venous outflow issue. For vascular pedicle, Doppler monitoring is valuable technique in Doppler emittance of robust and triphasic Doppler signal and corresponding to the rapid antegrade flow during systole and transient reversal of flow during early diastole and slow antegrade flow during late diastole. If all are present, that is our sign of the viability. Hayodo and colleagues reported mean post-operative re-exploration time for successful salvage was 1.3 days, and after 1.3 days, like 3.9 days, which was the failed salvage. Post-operative pain management, according to the WHO guidelines, well validated step regimen for the treatment of the pain according to the intensity and known as the WHO ladder. The five essential concept in the WHO approach uh, to drug therapy of cancer pain is by mouth, by the cloak, by the ladder, and for the individual and with attention of details. By the mouth, the oral route is the standard route for analgesic, including strong opioids. Injections needs professional help and are themselves a source of pain. By the cloak, if pain is persistent, it may require repeat of the analgesic. Analgesic should be given regularly and prophylactically. Explain regarding side effects like red flag signs to the patient and the responsible caregiver. Management in step first, we can use non-opioids plus minus adjuvants. These includes like paracetamol and NSAIDs. Example, etoricoxib, ibuprofen, naproxen, and diclofenac. In step second, we can use opioids and plus minus weak opioids and plus minus non opioids like codeine, tramadol, and dihydrocodone. Codeine is prodrug that is metabolized to the morphine. Tramadol, it is a synthetic opioid and less risk to the respiratory depression and addiction potential. It has dual action mechanism, partially via opioid receptors and inhibit the uptake of non-adrenaline like and serotonin, and this dual action is synergistic. Adverse effect like nausea, vomiting, orthostatic hypotension, tramadol, and it is contraindicated in the epilepsy and patient taking serotonergic medications. In step 3, we can use strong opioids. It is for moderate to severe pain, and strong opioids is morphine and oxydone and the fentanyl. Uh, it can be administered via various routes like IV administration, oral, transdermal patches. Morphine is a potent mu agonist drug, and it is always start on immediate release tablets like 5 to 10 milligram and for hourly. Adverse effects is nausea, constipation, vomiting, and sedation. For opioids, that cause nausea and vomiting, so we can add antiemetics drugs like metoclopramide and ondansetrons, and also we use stimulant, laxative, and stool softener for the during the tramadol and opioids use. Fluid balance after the post-operative care. There are the three principles of the management of the fluid balance. First is correct any abnormalities. Second, provide the daily requirements. And third is replace any abnormal and ongoing losses. Ideally, any abnormalities will have been identified firstly and corrected during or before the surgical procedure. The normal maintenance fluid required will vary depending on the patient's age, gender, weight, and body surface area. Basic requirement is total body water is 45 to 60% of the body, and distribution is two-third is intracellular compartment and one-third in extracellular compartment. In extracellular compartment, 25% is plasma water and 75% in the interstitial fluid. Daily requirement of fluid is 2 to 3 liter for a 70 kg adult. A daily fluid less 1500 ml via urine and 500 ml via other sites like skin, lungs, and stool. Electrolytes in extracellular compartment. Fluid, sodium is predominant, and in intracellular fluid, potassium is predominant. So basically, daily sodium required is 100 to 150 millimole per day, and potassium required is 60 to 90 millimole per day, and magnesium is required 1 gram per day. And fluid volume should be 1.5 to 2 ml per kg and per hour. Replacement of the fluids: 1 liter of the 0.9% saline plus 1 to 2 liter of the 5% dextrose, and this is the isotonic with the plasma, and that contain 154 millimole per liter sodium and chloride. If there is a hypokalemia, then we add potassium as needed. Maintenance of the oral hygiene after surgery, we can use a chlorhexidine for this, and is available solution is 0.2%. 1.12 is effectively equally effective for gingivitis, and recommended as 1:1 dilution with water for mouth hygiene. We can use also povidone iodine, and it is effective for the mucosal infection but not for plague, and use is limited to the 14 days because iodine absorption risk contraindicated in the thyroid disorder and lithium therapy, and side it can cause mucosal irritation and hypersensitivity. We can use for oral hygiene like hydrogen peroxide with the 3% solution and diluted with 1:1, useful for the if gross plaque is deposit. It acts as an oxidizing agent against anaerobic bacteria and has a mechanical cleaning effect. So, helpful in the wound dehiscence with debris accumulation. Adequate suction is needed to remove froth. Other anesthetic mouth rinses can be used like benzocaine and the benzodiazepine hydrochloride. Suction should be done by the Yonkawar suction, and removal for pool, saliva, blood, and mucus, and pus or any other secretions. This is uncomfortable for patients and can be predisposed to the drooling. Caution should be used through and areas where free flap and skin graft can be placed. Mobilization after surgery, early mobilization encourage pulmonary ventilation to improve pulmonary ventilation and reduce venous stasis. For non-mobilization patient, we can use aggressive physiotherapy for breathing and pneumatic cough compression and heparin to prevent deep vein thrombosis. Heparin administration timing depends on procedure and hemorrhage risk. Drains and catheter should be monitored and infection risk drain can be assessed point for infection. Efforts are made to prevent and contamination, and drains always in neck drains should always we watch for any chyle leak. After the drain, after the matlab post operative period, drain should be removed once they serve as purpose. If longer time drain stay, then infection risk of infection may increase. Drain content and volume should be recorded daily. If there are large volumes present in drain, then IV replacement should be done. And catheter removal should be done after patient's mobilization. Drain removal criteria: when drain volume less than 20 ml for 2 consecutive days. Communication, early communication for cancer patient is beneficial. Post operative reassurance, patient often seeks update on the procedure and recovery. Tell about normal tubes, lines, and equipment should be explained as routine, not signs of complication. And unexpected complication discuss with the patient, ideally with their relative present, depending on timing and situation. Nutrition and swallowing management. Weight loss is the key indicator of nutritional status in cancer patient. Malnutrition affect 40 to 80% of cancer patients due to the tumor biology, surgical treatment, and psychological factors. So, nutritional status is the independent predictor of survival, especially in head and neck cancer patient. Malnourished patients have higher risk of infection, delayed wound healing, and increased post-operative morbidity and mortality. Malnutrition increase metabolic activity, leading to the breakdown of skin and muscle to maintain vital function. Nutritional balance essential for cancer patients undergoing treatment to prevent complications like enteric fistula, wound dehiscence, and carotid rupture. Infection and injury cause negative nitrogen balance and muscle loss. So impact is malnutrition, impair immune function, tissue repair, decreased tolerance for treatment, daily energy requirement 25 to 30 kilojoule per kg per day for critically ill patient. Energy from carbohydrate about 60 to 70% calories, from fat 25 to 30%, and from protein 1.2 to 2 gram per kg per day. And amino acid is necessary to restore nitrogen balance and prevent muscle breakdown. And early speech therapy should be started. Early consultation for a swallow evaluation to reduce aspiration of pneumonia risk. Enteral and parenteral nutrition support. Post-operative nutrition prefer is enteral feeding. If is the gut is functional, that we use enteral feeding. Benefit of enteral feeding: easy to administration, well tolerated, support gastrointestinal barrier, and promote It promotes mucosal growth, more efficient, less expensive, and has a fewer metabolic complications like hyperglycemia, cholestasis, and fatty liver as compared to the parenteral nutrition. Nutritional component for the wound healing like vitamin C, A, E, and zinc is a cofactor in the wound repair. Vitamin C is essential for critically ill patient to prevent deficiency and promote healing and should be given 1 to 2 gram daily. Vitamin E enhance macrophage recruitment, phagocytosis, and cell-mediated immunity. Vitamin E is likely supportive for wound healing, and though its role is unclear. Zinc is vital for the DNA and RNA synthesis, protein production, and cell proliferation. Deficiency impair wound healing, but supplementation is only beneficial with actual deficiency. For deep vein thrombosis, in post-operative period, in 60% cases, deep vein thrombosis is silent, and in 40%, it symptomatic like calf pain, tenderness, and leg edema or Homan sign. Diagnosis based on ultrasonography and Doppler ultrasounds have greater than 90% sensitivity and specificity. The risk of deep vein thrombosis in head and neck procedure is 0.6%, and this risk is assessed by the Capirini risk assessment, and it is based on the 40 risk factor categorized by the total risk score. So basically it is in three categories: low, moderate, and high risk category. In low category there is a 0 to 4 total score, moderate 5 to 8, and in high greater than 9. What is Homan sign? Homan sign is if patient dorsiflex her foot, then pain and tenderness around the calf muscle. If Caprini score is 5 to 6, then we use only chemoprophylaxis. If Caprini score is more than 7 or equal to 7, then we use dual prophylaxis like chemoprophylaxis and mechanical prophylaxis. And we can give heparin 20 to 30,000 units per day, and with the APTT control 1.5 to 2.5. Duration of the heparin for DVT for 5 to 7 days, and replace after this replace with the warfarin. And warfarin dose adjust according to the INR. Heparin treatment discontinue once full anticoagulation is achieved, and the warfarin continued for 3 to 6 months to prevent further thrombosis. Hospital acquired infection common types include bloodstream infection, pneumonia, urinary tract infection, and surgical type site infection. Cancer patients have 3 to 4 higher risk of the severe sepsis and hospital acquired infection, especially from multi drug resistant bacteria, leading to the therapeutic failure and higher mortality. Vulnerable groups for the hospital acquired infection: patients with neutropenia or hematological malignancies are particularly at risk compared to those with solid tumors. Tracheostomy care in head and neck cancer patient. Tracheostomy cuff pressure should be maintained between 20 to 25 centimeter of H2O, and it should be measured in every shift. Tracheostomy site should be clean with normal saline, and inner cannula remove and clean as needed. Early decannulation should be done in head and neck cancer patient. So basically, decannulation is removal of tracheostomy tube, including safe procedure decision or and post-operative surveillance. Prerequisites for early decannulation: uh, uh, effective cuffing and swallowing should be present before decannulation. Patient should be clinically stable and normal, with normal vitals, and cuff deflation is required, and occlusion test should be done before the decannulation to rule out airflow obstruction. In occlusion test, close cannula opening with cuff deflated for 5 minutes. If there is no obstruction, then we should start for the decannulation. And capping trial for 24 hours. If and there is no aspiration present before the decannulation. If any symptoms of the aspiration present, then we go for diagnostic bronchoscopy and video fluoroscopic swallowing study for rule out the aspiration and finding cause of aspiration and any obstruction. And suction before decannulation, less suction frequency and decannulation timing in head and neck cancer patient before 10 days as normal, because for longer the tracheostomy tube they will habitual for it, and so we early start in head and neck cancer patient. If patient is smoking during and before the procedure, so higher risk of the in this patient higher risk of the fail decannulation. After decannulation, tracheostomy tube should be removed and clean the site and cover the site with the dry gauze and dressing, and instruct to patient to apply pressure over the dressing with fingers when they talking and coughing, and changes dressing daily as needed. If moist secretion present, then change the dressing. Thank you.
Thank you, Dr. Meena. Role of intraoperative measures which can actually prevent these post-op complications.
Yes, sir.
Maybe perfect hemostasis, then irradiated patient, how to handle these patients. You have to put some vascularized flap over it.
Okay.
Then role of prophylactic tracheostomy. When do you do prophylactic tracheostomy? Then few other things like post-operative hemorrhage, especially thyroid and oral surgery or skull-based surgery. If there is a post-op hemorrhage, how do you deal with it? Then I don't know, you must ask your seniors, are they using warfarin as antithrombotic agents or something else? In our hospital, we give Clexane.
Sir, in your hospital also we give Clexane.
And then followed by Ecosprin.
Yes, sir.
That's all.
Yes.
But I don't know, if your practice is warfarin, then it is fine. Flap necrosis, when do you intervene? That is important. Okay.
Okay. So,
And the other complications which you should have covered is parotid surgery, eye care,
okay, sir.
surgery of the skull base, what are the special precautions to be taken, and CSF leak, chyle leak,
Yes, sir.
and complications after thyroid surgery, which are very important, and some of the complications like post-op psychosis, psychological issues and emotional issues. And the other thing which is very frequently now asked by the newer examiners is ERAS protocol.
Yes, sir.
How does it affect the outcome? and how does it help you in preventing complications? I think there is a in the chat box there is a question. No. Okay. There is some remark. In our institute, every free flap reconstruction has a tracheostomy as per protocol. It is mandatory each time. This could be there could be variation in each institution. Every free flap does not need a tracheostomy unless it is a bulky flap. We at our place in Rajiv Gandhi Cancer Institute don't do prophylactic tracheostomy in each and every free flap. We choose our patients and then only do it. If there is a midline alveolar defect which has been repaired, we will do it. Laterally placed mandibular defect which has been reconstructed with free fibula, there is no need to do a tracheostomy. Tongue anteriorly placed free flap, there is no need because it is fully functional tongue and tongue can deal with saliva well. We don't do it. Posteriorly placed tongue lesions or flaps reaching onto the base tongue area, we definitely do it. If the flap is bulky flap or a patient has been heavily irradiated before, then you are putting a flap. Tracheostomy is a must. So there could be institutional variations. I'm not saying that you should not do it, but we don't follow that every free flap should have a tracheostomy. Okay. Dr. Deepak Sareen is not there. I thought if he was there, he could have added a few more points.
Yes.
चलिए ठीक है डॉक्टर मीना जी, good, well done.
Okay,
Covered all points. Thank you.